Finals SAQ 74, Intrauterine Fetal Death. A. What are the implications of managing a patient with Iufd at 36 weeks gestation? Delivery decision. Induction, expectant or occasionally cesarean section due to previous obstetric history or patient preference, or because the underlying cause necessitates this, such as uterine rupture. Psychological aspects. Senior midwife experience in caring for women with Iufd, early conversation with obstetric anesthetist, dedicated room for care of women experiencing fetal loss, away from the noise of labor ward but still with the facilities to provide level of care required, good communication among all involved healthcare professionals to avoid the possibility of lack of awareness of the situation and subsequent insensitivity. Pain relief options are discussed in Part B. Level of care. Complications may have caused the Iufd or resulted from it. Obstetrician-led management should be employed. One-to-one midwifery care if possible. Meows charting. The chart is included here for completion. Delivery suite is level 1 care. Ward is level 0. The patient may need to stay in level 1 care post-delivery. The patient may require level 2 or level 3 care depending on the circumstance. Implication of underlying cause. The cause may remain occult. The cause may have major implications on delivery management. In utero deaths can be associated with concealed abruption, sepsis and DIVC. Abruption, preeclampsia, uterine rupture, thrombophilia, sepsis and maternal diabetes will all impact on intrapartum care and delivery mode. B. How does the presence of an Iufd influence the choice in the method of pain relief in labor? Early consultation with the obstetric anesthetist should be facilitated to discuss expectations and wishes. Maternal pain experience may be greater due to psychological distress and also if induction is necessary. There is therefore a greater need for effective pain relief and epidural may be optimal. There is no need to consider utero-placental transfer of drugs. Hence, better pain-relieving opioids such as morphine and diamorphine may therefore be used instead of petidine, and these drugs may be given as PCA. Cause or consequences of Iufd may contraindicate regional technique, such as in the case of sepsis, preeclampsia with deranged clotting or thrombocytopenia, hemorrhage, and Iufd resulting in DIVC. Remifentanil PCA is contraindicated according to protocols. There is lack of experience with remifentanil PCA in Iufd. Recent adverse incidents associated with its use in the presence of Iufd precludes its use. C. Which abnormal hematological results would contraindicate epidural analgesia? These include signs of maternal sepsis, such as raised white cell count, thrombocytopenia, which may occur in severe preeclampsia or HELP syndrome, and deranged coagulation profile, and low fibrinogen, which may accompany low platelets in the presence of DIVC due to abruptio, uterine rupture, or occasionally due to Iufd itself. Coagulopathy may occur in severe preeclampsia or HELP syndrome. Abnormal coagulation may also be present in maternal thrombophilias. Comments. The question was written because the anesthetist is often involved in the provision of analgesia for labor under these circumstances. Section A was specifically asking about the implications of Iufd. The implications of Iufd focused on psychological distress, methods of delivery, mandatory level 1 care and possibly level 2 care, identify possible causes of Iufd, provide effective analgesia and consider sedation. Additional Q&A. September 2017 FRCA. A woman who has had an Iufd at 36 weeks gestation in her first pregnancy is admitted to your delivery suite for induction of labor. A. Describe the important non-clinical aspects of her management. This includes one-to-one senior midwifery care, which is trained in caring for women with Iufd, good communication between all involved healthcare professionals to avoid possibility of lack of awareness of the situation and insensitivity, clear discussions with the woman regarding expectations and wishes for the delivery. Aspects to discuss includes pain relief, presence of friends or family, contact with the baby after birth, and arrangements for mementos to be created, such as photos, hair cuttings, and footprints. Dedicated suite or room away from noise of delivery suite, ideally with provision of non-clinical area, where the woman may be with her birth partner, families or friends before delivery, and may spend time with her baby if desired after birth. However, the location for delivery is ultimately determined by the mother's clinical condition. The answer for question B can be found in part B and C in the previous question. C. If this patient requires caesarean section, what are the advantages of using regional anesthesia other than avoidance of the effects of GA? This includes post-op analgesia is better with early mobilization. Regional anesthesia facilitates early contact with the baby. Regional anesthesia permits clearer recollection of events that may be important to the woman. Fewer drugs are administered with less hangover than after GA. Regional anesthesia facilitates the presence of the partner at delivery, and there is minimal risk of aspiration and lower risk of anaphylaxis. Comments. This question was removed from the exam after marking, but no candidates were disadvantaged by its removal. The reason for not including in the final scores was there was confusion amongst candidates about whether the IUFD had occurred in a current or previous pregnancy. These are my references. Thank you.